to us as hosts, and we will pass that over to the panel. So first, before we do that, we'd like to introduce Dave Quigley, who is Chairman of Optometry Scotland, to do an introduction. Thank you.
Thanks, Alistair. Good evening, everyone. It's great to have you all join us this evening. We're clearly at a very interesting and probably a worrying time in our careers and in our lives, I guess, with the scale of this pandemic that we've experienced. I suppose just to put things in context for this evening, this is really designed to give you as much information as we can over this short period. We're really keen to interact with you as often as possible, so please feel free after tonight to drop as many questions into the feed as you possibly can. We'll answer them later, and if we get enough requests, then we may just have another one of these in phase 3 when we get there, and maybe a little bit later after that. So the other thing, just by way of a backdrop and thanks, although many of us have been frustratingly not in the workplace for quite some time, some of us have, and I think it's fair to say that the work that's been provided by Optometry, by community eye care, has been absolutely tremendous. We've really done an amazing job. There are hundreds of thousands of inquiries have been made into practice over the last 3 months, and many of them have resulted in some care being very effectively delivered remotely, and with small numbers and very well managed small numbers eventually being referred into secondary care. Our relations with ophthalmology have been tremendous as well. We've had some great interactions with ophthalmology. They've been very supportive, and in future I think we'll be hoping to support them. Our working relationship with the government has been excellent, and whilst you might not be aware of that on a day-to-day basis, we must extend our sincere thanks to our colleagues, Mike Stewart, Janet Pulley and the whole team there, for the help and the support that we've had from them over these last 3 months, and obviously the ongoing support of GOS and the Scottish Government. I'm sure we all have appreciated that hugely, and hopefully for some time to come. But that's still to be negotiated, of course. I think as well, the Optometry Scotland team, you probably don't know many of us. You'll see some of us tonight. We have our panel. We're a very broad church in Optometry Scotland. As many of you may know, I'm a Specsavers person. We have some multiple representatives in Optometry Scotland, and we have many independent ones too. We have AOC members, and we also have optometric advisors. So we're a very, very broad church. Much and everything that's done, everyone's work briefcase is left at the door, and everything that we do in the room is all to do with protecting community eye care, continuing with that tremendous world-class service that we have offered before this pandemic, through this pandemic and beyond. And our thanks are extended to all of you for doing such a great job over the last few months. It is a worrying time. That said, I'm very confident about the future for all of us, simply because we are a great bunch of professionals. I think when you see what's happening in other sectors, the work that we do in community eye care is tremendous. I'm sure that next week, when we eventually go back into offering face-to-face services for emergency and essential eye care, we will obviously go in with PPE provided by the NHS. We provide you as much information as we can with as many links to all of the professional bodies, and I understand that some of that doesn't necessarily conflict, but it doesn't always align because different countries are doing different things, but we're trying very hard to give you as much information as possible. Whilst I'm on, I think it's very important as well to thank all the professional bodies with whom we've worked very, very closely across the 4 nations, and with representatives for the 4 nations as well. So just as it's been a team effort in Scotland, it's been a team effort across all the nations, and I think we set some friendships and relationships that will carry us well into the future. So really, from next week, I wouldn't really say that you should be worrying too much, because we know that we're going to behave professionally. There's lots of support there. There's lots of resource out there to help you. You know where to find us. You know where the professional bodies are. Contact any of us and we'll be able to point in the right direction. As far as the public is concerned, that is the only unknown factor with regards to how things are going to go from next week onwards. We can't really predict how they're going to react. I think we've got a bit of an idea of what's happening in other parts of the UK and Ireland. Certainly the pubs are going to be busy. I suspect we will be too. So it's just a question of managing your own expectations. It's going to be a tough couple of weeks. Possibly after that we might get into another phase. But I think if we just remain cool, calm and collected, everything's going to be just fine. So on that note, I'm going to hand you back to Alistair, Please keep the questions coming. It's been great, the response we've had. We very much look forward to hearing from you throughout this evening and hopefully beyond. So thanks very much. Good luck for next week, and back to you, Alistair.
Thanks very much, Dave. That was very comprehensive. So, time to introduce the panel. My name is Alistair Duff. I'm an independent optometrist and independent rep for OS, and my co-host this evening is Robb. Emma, would you like to introduce yourself?
Hello everyone, I'm Emma. I'm an independent prescribing optometrist and I'm the partner in Specsavers Newton Mearns. I am on the exec for Optometry Scotland as the Specsavers representative.
Great, glad to have your help this evening, Emma. And next on to possibly the busiest optom during this crisis, it's Julie Mosgrove. Julie is also Vice Chairman of Optometry Scotland. But introduce yourself, Julie.
Hi everyone, so I'm Julie Mosgrove, Vice Chair of Optometry Scotland. I'm also an independent prescriber and I'm the Retail Director of Duncan & Todd. So yeah, I first came on to OS a few years ago now as Grampian AOC representative, and then laterally joined as Duncan & Todd representative. And then I stepped up to Vice Chair as of last summer. It's been a busy year.
I know, I told you that. Nice to have you, Julie. Right, next we have Kevin Wallace. Now, Kevin is our regulations expert. If anyone's ever been to his webinars, I've heard a rumour that he actually papers his walls with the regulations. So, Kevin, introduce yourself.
Thanks. Hi, I'm Kevin Wallace. I'm an IP optometrist based in Edinburgh. I'm advisor to the AOP and I'm currently the AOP's rep on the OS exec.
And you could be the busiest man with questions this evening, so hope you're ready. Kevin did actually say we'd wait until midnight, folks, to answer all the questions, so keep them coming for him. Next, we have Brenda Rennie, and Brenda is our ABDO representative on the call tonight, and also on the exec board. So, Brenda, introduce yourself, please. Oh, we're muted.
Apologies. Hello, my name is Brenda Rennie and I am a dispensing optician and I am the Association of British Dispensing Opticians representative for Optometry Scotland. Thanks
very much, Brenda. And last but not least on our Optometry Scotland panel for this evening is Mr. Frank Munro. Frank is actually one of the founding members of Optometry Scotland. Feel free to go and watch the video about him, Hal and co. It's definitely worth a watch. And I know he doesn't look that old, but Frank, introduce yourself.
Well, thanks, Ali, but I can assure you I am that old and I look it. Good evening, everyone, and welcome to this webinar. A great opportunity for us to give you a little bit of feedback and answer some of your queries, and I'm looking forward, along with the rest of the panel, to sharing this evening's activities. As some of you know, I'm an advisor to Optometry Scotland. I'm also acting as optometric advisor to Lanarkshire just now to a sickness of a colleague, and I'm lead optometrist for South Glasgow. And I'm also I practice, and I'm an IP optometrist working in Glasgow and Lanarkshire. Thank you.
So as you can see, the Optometry Scotland panel is a broad church, as David said, but we also have a guest this evening. Some say he's the nicest man in Scottish Government, and he's certainly helped us through this crisis. If anyone's met him, they'll know that is definitely the truth. We have Mr. Mike Stewart on from Scottish Government, and I think that definitely shows how open the government have been in working with Optometry Scotland during this crisis. So Mike, if you could tell us a bit about what you do in Scottish Government.
Yeah, thanks very much. So yeah, my name's Mike Stewart. I'm the Community Eyecare team leader at the Scottish Government. I work with Janet Pooley, Dr. Janet Pooley, our optometric advisor, and with a couple of, 2 or 3 other colleagues. We work very closely within the government as well with our secondary care colleague, Jackie Dougal as well. So it's quite a small team, but very well joined up on working. And so essentially we're in charge of general ophthalmic services. We also sort of work with other colleagues as well on visual impairment policy as well. And I've been in the post, as I say, about 3 years now. And we've taken, you know, as you said, Alistair, we've taken a very sort of consultative and collaborative approach with all of the work that we've done, you know, over the last couple of years, but especially when we've been going through these sort of terrible times with COVID. And I think the relationship between, you know, the Scottish Government and other key stakeholders, including Optometry Scotland, has been, I think everyone would agree, has been really excellent and really productive. It's very much a Team Scotland approach to get us through all of this, and also to capitalise on the opportunities we have coming out of this as well. So I think that's me.
Thanks very much, Mike. So I think it's time to move on to the frequently asked questions that we have. Now, what we have done is we've collated Mike's questions first, because obviously he's our guest. So let's start with Mike. So myself and Emma are going to alternate questions. So I'll start if you don't mind, Mike. Yep. So the first question we had through is intra-referral to an IP optometrist still admissible as it was during lockdown?
Yeah, okay, so as we set out in the last PCA that was sent out last week, so intra-referrals within general ophthalmic services historically has never been sort of permitted, but we did allow that during lockdown in phase 1 as one of the means of sort of ensuring that with restrictions on sort of face-to-face care in the emergency eye care treatment centres and with optometrists and practices managing patients remotely, we did allow that for a temporary basis, and we obviously reflected that in the additional payments that could be submitted via e-ophthalmic as well, with an enhanced supplementary code. Now that we're into phase 2 and we've got practices resuming face-to-face emergency and essential care, we've, as we set out in the PCA, all of those additional payments have ceased. But so what it means is that until further notice, intra-referrals are not permitted within general ophthalmic services again. So if you are doing that, then please don't be submitting any claims through the e-ophthalmic system for those. However, under the GOC's rules relating to the injury or disease of the eye, not a lot of people probably are aware of this, but actually there is already provision within that legislation, and the full reference to the particular provision is in that PCA. I think it's paragraph 30. So you can go away and have a look at it for yourself, but it does give the facility there for referral to an independent prescribing optometrist with, it talks about people with relevant sort of clinical qualifications, etc. So you have always been able to actually do an intra-referral, but just not within general ophthalmic services. Now, what we are actually looking though as well is that we're actually working within the government, recognising that intra-referrals actually was obviously a big success during lockdown in phase 1, and it clearly worked. We're looking to develop a national framework for intra-referral. So the aim would be that we'll have to secure some additional funding for that. But the aim would be that if we do secure that additional funding, we would also amend the general ophthalmic services regulations to permit intra-referrals. And then we will communicate that once that is able to be developed. So no guarantees, but it is certainly something that we're working on.
I think that's great to hear. Hopefully that moves us going forward. Thank you very much.
Thanks, Mike. So the next question is, a lot of practices are now being given near me, and we've also been examining patients virtually during the pandemic. Will this still be permissible?
Yeah, so it's certainly permissible during phase 2. It will continue to be permissible during phase 3, which is about increasing the capacity within practice premises for emergency and essential care. Clearly, this is something that has worked extremely well during lockdown in phase 1, and it's that whole system about optometrists managing patients remotely and being able to claim obviously for consultations, minimise the number of patients who did need to be seen face-to-face in the emergency eye care treatment centre. So even though the emergency eye care treatment centres will be coming to an end from Monday in most areas, and with practices resuming care, certainly remote consultations will still continue to be permitted. We will have to review that again for phase 4, because phase 4 of the Scottish Government's recovery route map envisages the resumption of routine eye care. So at that point, we will need to consider whether those arrangements still continue at that point. So, but certainly for now, for phase 2 and phase 3, they will still continue. Yes.
Okay, thank you.
Great. Now this next question has been asked quite a lot. Will IP optometrists still receive the larger enhanced fee?
Yeah, so as we set out in the PCA, there was a package of sort of remuneration that we put in place for lockdown in phase 1, recognising that we needed to ensure that the whole system was working and we had enough sort of practitioners managing patients remotely. And certainly, I think again, all optometrists and all people that were providing sort of care, whether face to face in the emergency eye care treatment centres or remotely during lockdown in phase 1, everyone, it has to be a massive thanks to everyone there. So, although we have stopped those additional payments for now, as set out in the PCA. Again, that is something that we are looking at, along with intra-referrals and along with additional funding for community optometry to support the hospital eye service in their recovery and remobilisation as well. So we will, again, if we're able to secure funding for that, then we will reintroduce that hopefully at a later date, and that will come back in. So just as a reminder as well, just while everyone's on the call, that as the PCA set out, please submit any claims for such activity, the 2.8 and 4.8 claims. If you could make sure you submit them via the e-ophthalmic system by no later than the 15th of July, because that's the cut-off date for those payments being made.
Great. I think another positive move, obviously during this crisis, we've had to move quickly, but it sounds as if the government are thinking about the future and how we can introduce some of the positives from this. But thanks.
And the next question for Mike is, will there be a uniform financial and systemic arrangement across Scotland for managing acute eye conditions in the community?
Yeah, so I think those plans are well underway now within the government as well to explore, what we can do, because we all know that the hospital eye service will be under, be under pressure, and their ability to see the same number of patients they were able to do pre-COVID will be restricted, and so community optometry will play a really important part for the whole eye care system going forward. So outside of general ophthalmic services, it's certainly something we're looking at the moment, similar to the things I mentioned just there about intra-referrals and the independent prescribing payments. And so clearly general ophthalmic services as a sort of national sort of system across Scotland clearly works, a once for Scotland approach on things. So again, further information on that will follow in due course, but we certainly sort of hope that we have a sort of a national sort of funding package available. I think it probably doesn't do patients or practitioners well to have a sort of postcode lottery in terms of service provision, going forward.
Thank you.
Yes. The next question cropped up a few weeks ago, and basically looking to the future, are there any thoughts around whether any support is required for community optometrists in relation to the very limited number of recalls we're going to have next year in April, May, June, July? So that's 2021, and maybe even the subsequent years beyond, because this might impact us going forward.
Yeah, I mean, it's a short answer, but we will definitely be considering that. Again, can't give any guarantees, but we will need to consider that certainly as we get into phase 4, when we resume routine eye care.
Great.
Thanks, Mike. So next question is, am I expected to have my practice open for face-to-face emergency and essential eye care in phase 2 for the same days or hours pre-COVID?
So clearly that'll be up to the practice owner to determine, but no, we're not expecting, certainly within phase 2, and I don't think even within phase 3, I think it'd be unreasonable to expect that a practice is going to remain open for face-to-face care for the same, the same time that in days and times that it was pre-COVID. What we are asking practices to do in returning the declaration form to your local health board, what you are essentially saying is that, and it's a condition of continuing to receive the monthly support payments as well, is that if a patient does need face-to-face care, you're essentially saying that there will be the ability for that patient to be seen face-to-face in that practice, and as it was mentioned earlier, the Scottish Government has arranged for PPE to be provided at no cost as well to practices for NHS services. So that's essentially, I mean, obviously if that's an issue, then that is something you have to take up with your local health board. But we have obviously advised the local health boards that that around that expectation around about opening hours. It's more about just as the patient numbers are obviously reduced at this current time. It's about just being reasonable and ensuring though that there's good access for face-to-face services for patients where it's considered clinically necessary by the optometrist.
Perfect, thank you.
And this next question relates to that as well, because if I own more than one practice, can I provide face-to-face care from only some of these practices and keep the others closed?
Yeah, so the short answer to that is no. And again, is part of the process of returning an individual declaration form for each practice. You can't submit one form for a group of practices. By submitting that and signing that declaration form, you are, again, as I said in the previous answer, you are committing to provide a face-to-face service from that practice. Clearly, obviously at this time, the numbers of staff and that and the hours of working in that may be, again, not there as what it was pre-COVID. So if there's a situation, I'm just using it as an example, where perhaps you've got one optometrist and you've got this quandary about having two practices relatively nearby, it would be up to local arrangements to ensure that that the optometrist would be expected, for example, to provide cover over those two practices. So it will require a slightly different way of working for practices to work around that. But that's the position.
No, that's brilliant. I think that's understandable. We need to try and keep the communities open. So, Mike, I've just heard it's your wife's birthday, so thanks very much for joining us this evening. And I know you have to dash off, but if anyone's got any questions for Mike, again, feed it into the Facebook link below. OS are meeting with the government weekly basis, so we can get those answers for you and get them back to you. So thanks again, Mike, for joining us this evening. It's much appreciated.
Okay, thanks very much. I'll stay on if it's okay.
Oh, yeah, you've got time. If your wife lets you.
You're allowed, yeah. So we'll head over to the questions for the panel now. So the first question for the panel is targeted towards Julie, if you can help us with this one. The question is, can I recall patients? And if not, what communication is acceptable?
Well, I think it's kind of answered in the PCA, where blanket recall, just inviting patients back in for a routine appointment, is not acceptable kind of at this time. But practices are able to communicate with their patients. And for example, things like contacting them and advising them that they're now open for emergency and essential care. I think as long as the message is clear to patients and you're communicating kind of well with them that it is for emergency and essential, then that would be absolutely fine.
Thank you.
Brenda, we've got a question for you, if you don't mind. It would be great to have specific advice and guidance on how to exactly sterilise frames and surfaces. Examples of products we can use would also be helpful.
Okay. Frames, you really need advice for the cleaning on the frames, and that depends on the frame material. All the manufacturers are providing information which applies to their frames. Therefore, we should really read our suppliers' recommendations before we use anything on them. The links for the disinfectant can be found on the ABDO website and can also be found on Optometry Scotland website. Irrespective of all this, it should really be done in steps for going through with the PPE and cleaning your hands and things like that. Personally hand the frames over to patients to begin with and keep them separate from the rest of the frames to make sure you sanitise them all. The least expensive way is just to use a mild detergent with a gentle pH, rinse them with lukewarm water and then dry them off with a microfiber cloth that you can then wash at 60 degrees and reuse should you wish. You can also go the clinical way and go with a UV lamp, or you can use an ultrasonic cleaning device, and all those methods are really good. If there is no access to running water, you can use hydrogen peroxide wipes, but you've got to be aware again that some of these might damage the materials of some frames, so always be careful with that. Big things not to do is don't use rub alcohol sanitizer onto the glasses. Avoid using products with high concentrations of acid as they damage it, and do not use any other specific sanitising wipes. You must check with the manufacturer and make sure that because they will determine the best recommendations for the material of their frames. For the surfaces, all communal areas should be cleaned with just a household disinfectant. You don't need anything too fancy for that, or alcohol wipes. You should make sure you clean down all the surfaces. Anything on them will be touched regularly, such as door handles, light switches, phones, computers. And at the dispensing area, all hard surfaces should be cleaned before and after each patient, just to make sure you can keep everything good.
Great, thanks. I think I certainly watched the AOP's video on the surface cleaning, and it was pretty comprehensive. And that those I've downloaded all my different frame manufacturers' guidelines have been really handy, so definitely worth checking out. Thanks very much, Brenda.
Brenda, you're in the firing line again. Another
Okay.
for you. So some practices are planning on asking the patient prior to booking if they require a dispense and setting aside an allocated slot for this. What's your view on this?
My view is it really depends on the size of the practice, whether to allow physical distancing. It could have a positive or a negative impact. In some practices, I think it could be a good idea. It would allow the correct allocated time for each patient, because obviously we need to make sure that we can allocate the time for the dispensing as well as the eye examination. When the patient phones up for their appointment, most of the time they will know if there's a change in their vision and if they really would prefer to have an update in their glasses. So it would be best to book that time, I feel, to do that. The only thing that would be, if they were being referred for an ocular condition instead of updating their lenses, there would be unused time in the practice for that. Again, it's just a balance, but I don't see anything against doing that. I think it's a good idea.
Good, thank you.
Thank you.
Great, don't mind. And this has definitely been on the agenda today. Should I be wearing scrubs to work?
No, is the short answer. The longer answer is probably more detailed, that I think you absolutely have to be wearing something appropriate for a clinical environment, short sleeves or at least sleeves that can be rolled up, and something that's easily washed. Because, and if you watch the AOP webinar, I would recommend that as well. You wouldn't be surprised to know that the virus, or any virus, is destroyed quite easily by a regular wash with detergent. So something that can be washed, you know, a cotton short sleeve shirt and trousers that can be washed, changed every day is absolutely appropriate. But scrubs is probably slightly excessive, but if you want to wear your pajamas to work, that's fair enough. I've been asked quite regularly about shoes as well, and I think it is quite a good idea to have a pair of shoes that you wear at work. And again, overnight, there's not a lot of things that will live on that surface overnight. So just leaving them in the practice overnight, wearing them again the next day is a good idea. And it just prevents taking things home with you, or at least into your car. Just another level of protection against cross-contamination.
Frank, do you have anything to add to that?
It's certainly not compulsory, but a lot of practices in my neck of the woods have chosen to use the scrubs as more or less as a uniform. As Kevin has pointed out, it's pretty easy to manage them. I've just they get washed and dried in no time, and they dry like a ribbon, and then you've got them ready for the next day. So a lot of practices are using them as an alternative, and it's obviously safe and it's reasonably economical. So it's entirely up to the practice and how they choose to deliver the service.
Great, thank you.
So the next question we have, again directed towards Kevin, is: I have sent back the practice's declaration. Will I hear from the NHS boards to formally acknowledge before opening my practice for face-to-face emergency and essential care?
Yes, so that's why the deadline was today, Thursday, because that gives the board time to respond to you tomorrow, which will be in time for you opening on Monday. So yeah, you'll get confirmation of that everything in your declaration was adequate and you're happy to open on Monday.
Great. That's good to know.
Great. Next question. Can practices who are located in an indoor shopping centres resume the provision of face-to-face care? And that's for yourself, Julie.
Well, I think optometry practices are obviously classed as essential businesses. So I would think the answer to this is yes, if the indoor shopping centre is open.
Brilliant. Easy one.
Again, Kevin, we've got you up again. If someone presents with broken spectacles and we deem it as essential, as it's been many years since they've been tested, is refraction enough if there are no other symptoms?
No, you're giving me all the easy ones to start with. No. I mean, we're still in a period of time where we need to be careful. We're not doing unnecessary things, certainly not getting people into the practice unnecessarily, but the Opticians Act still applies. If you've done a refraction, if you're performing a sight test, you have to then look at the outside of the eyes, the inside of the eyes, and anything else that is required. So your regular sort of test, IOP for patients over 40, that sort of thing. So you just have to remember that even in this situation, you have to do the normal test.
Great, thank you.
Next one's for yourself, Frank. Can small part-time practices triage via phone from home and attend the practice as required to examine patients? So I guess Mike's kind of answered that, but I'll let you go again, Frank.
Yeah, I think Mike has answered it fairly well. It's something that had come up during the discussions when we're moving into phase 2, and I think it's important that folk realise that the premises have got to remain, the term I like to use is active, so they're viable and accessible to patients, and that would allow them to get the GOS funding. But there are a large number of practices that have been mindful of their expenditure, they've been mindful of the financial challenges that they face, and some of them are tele-triaging the appointments and booking patients specifically for face-to-face appointments as and when required, and delivering the face-to-face emergency or essential care in the practice as and when it's needed, and that's certainly allowable in the current circumstances.
Brilliant, thank you.
So the next question, there seems to be conflicting advice. What are your thoughts regarding visual fields testing? And that is for all the panels, so if anybody wants to answer that for us.
Can I start then? That's almost the same question as a minute ago, in that, do I have to do everything I would normally have done? And the answer to that is yes, you need to do everything that's necessary. So if you examine a patient and think this patient needs their visual fields assessed, you should have assessed their visual fields. But it's absolutely not the time to be doing visual fields on everybody. You know, some people like to say I do visual fields on everybody over 30, say. That's not in any of the guidance, that's just a personal preference. At the moment, I would say that's unnecessary. That's exposing the patient and you and your machine to more risk than is necessary. So do it when you think it's clinically required, not just for the sake of, I like to offer a more comprehensive examination at this moment.
Can I just add to that, if you don't mind? There doesn't seem to be any evidence in the literature about visual field testing being putting patients or practitioners more at risk. But I would agree with Kevin, there's no point in doing non-essential activity. There's no point in doing visual fields just as a screening process without any meaningful gain. There are manufacturers who will advise you on how to clean the machine and how to clean the bowl by using a spray or whatever. But it's just the most important thing I feel is to ensure that the room is well ventilated, so there's a good circulation of air, because a lot of visual field kit tends to be in a smaller room to make sure the room is well ventilated, and that the staff wear appropriate PPE, whoever they are, when they're operating visual field kit, as it would be the same for taking digital images. So the full PPE on, including face mask and perhaps visors and gloves and an apron. Any activity within 2 meters, we should be donned up with all the PPE.
I think just to add to that as well, just thinking about the amount of time you're spending with a patient, and like both Kevin and Frank have said, you don't want to be just doing tests for the sake of doing tests, and you don't want patients having to go through lots of appointments or lots of time unnecessarily with yourself. So I think it is something just to treat each patient and assess the symptoms kind of in front of you and decide whether you want to put them through that check or not.
Great, thank you.
Great, can I just ask Kevin on that point? He was working in the Lothian EETC. How often did you end up doing fields, Kevin?
I didn't do it ever. I don't know about the others, but I don't think it was very often. It was a handful of times at most, but that was for emergency care, so that's a little bit different. In this phase of essential care, we'll maybe have more things like glaucoma reviews and that sort of things. I think it will be required a bit more now, but it's certainly not going to be something you're going to be doing every day. It would only be in those cases where you're investigating something in particular.
Brilliant, thank you. Next question again to the whole panel. Would seeing a patient who was asymptomatic upon presentation, but then is found to have COVID, trigger a call from the trace and protect?
Can I start with that one as well?
Yeah, go on.
The key with this, the first stage with this, if we go back a stage, is avoid this at all costs by screening patients before you're allowed in your building. You need to do this on the phone, you need to ask them the standard questions we're all getting used to now for the EETC access, and then double check when they arrive that since they phoned you, they've not developed a new cough and a fever and all the things we're comfortable with. And that's as much as you can do. But the rules for trace and protect is that anybody they had contact with 48 hours before developing symptoms up to 7 days after is a contact. So that 48 hours before they have symptoms is the period where you can't do anything about it. They were asymptomatic, so that's the scenario. So if they phone you and said, I've just been diagnosed with COVID, I was in your practice yesterday, what does that trigger? And the answer is, if it's a contact, you go home for 14 days. But the way to avoid that situation is it's only a contact if you were within 2 meters of them or you didn't have PPE on. So if you examined that person with your proper PPE on, you've got no problems at all unless you develop any symptoms, but that's a whole different thing. But it's not a contact like it would be if you'd had a conversation with them, like if it was a colleague. A colleague's a whole different thing. If you shared a tea break with a colleague and they got diagnosed the next day, that would be a contact and you would then have to self-isolate. But as long as you've got your PPE on, it's not something you have to do anything about.
Perfect. I think that's anyone want to add anything to that?
Well, the only other consideration would be if the patient presented and suddenly developed COVID positive symptoms when they're in the consulting room, then they need to be isolated in a safe place in the practice, and you would need to contact NHS 24 for advice and guidance. It's not happened very often to my knowledge, but that's another aspect of this that people need to bear in mind. Other than that, Kevin covered it pretty well.
Great. Just before we go on, we've had a wee question in the Facebook feed for Kevin. I wonder if you could clarify, Kevin, that IOPs and webinar comments, are they compulsory in all over 40s that we assess with refraction?
It's not so much with a refraction. Well, actually, I suppose it is. If you're saying that somebody's in for what you'd say would be a basic test, would be part of the thing. So a patient who's not seeing very well and you deem that essential and you perform a normal eye test, yes, that's now, we're back in the phase where IOPs should be assessed as part of that normal, not routine assessment, but normal eye test routine. That's a reasonable test to be doing at this time. Compared with 2 months ago, when we were really in quite a strict period of saying, just do exactly what you have to do and not anything extra. We're in a slightly different period now where we need to do the more normal tests.
Brilliant. Thank you very much.
Thanks, Kevin. So the next question is again for Kevin. Can we have some clarification in detail of what constitutes emergency and essential and routine eye care?
Yeah, well, emergency, I think, is the easy bit. Emergency we're quite comfortable with because we've been doing that for a few months. Patients present either with a sudden loss of vision or a sore eye or, all those things that are something you have to deal with quite quickly. Essential is slightly different in that there is the definition we've got in the PCA there of people that will have a longer term effect on their vision. So that would maybe be something like a glaucoma. Somebody you've been keeping an eye on, they were maybe down for a 6-month review in March. You've obviously not done that, but that might be the sort of thing you want to do in the next few months. And that would be perfectly reasonable to recall these patients for as well. So you could go down your recalls. You're absolutely not, you shouldn't be sending routine reminders at this point, but you could certainly send recalls to people who you wanted to see, or something like somebody not being able to see. And again, that's not an emergency, but maybe they've had a big myopic shift, they're struggling to function, they're struggling to drive. Now that people are allowed to get out a bit more, there are things that are going to affect their life and their personal well-being. So they're the sort of things we should be dealing with at the moment. Routine, I suppose, is everything else that's not essential or an emergency. It's just, we recommend you have your eyes checked every 2 years, or 1 year for some people. That's the standard stuff we do, and that's the ones that we're not going to be doing for a bit longer.
Perfect, thank you.
Yep, I think that's fair. Next one again for you, Kevin. Sorry, you're on a roll today. How much time would you recommend between patients?
And I think you're probably at least 10 minutes in this. And this is really just, again, my experience with this. I'm working in our EETC, and we had quite a clean environment. It was in our training clinic, so it looks like a hospital, really. It's got vinyl, everything, and not many things on surfaces. So you want your room to be as much like that as you can. But it takes about 10 minutes to change over between taking the patient out, cleaning the environment, everything the patient touched or you touched, taking off your PPE, washing your hands, putting on your new PPE, getting the next patient is probably about a 10-minute transfer. And the one bit where that gets really difficult is when the one time we got into trouble in our clinic was when we had lots of people with flashes and floaters. And often in practice in the past, you would leapfrog these people. You would dilate one and then go and get the other one and go back and forward, that takes you 15 minutes between each one, because you've got to change the whole room and change your PPE to go and get them. So it's a realistic 10 minutes extra on your appointment to get changed over before you get the next one in.
Great, thank you.
So no rest for the wicked, Kevin, this one's for you again. Can you clarify, since the GOC are saying private patients are permitted to be seen now, could we be contacting our contact lens patients' overdue checkups and getting them in prior to reopening officially?
Yeah, and I would go back a little bit further on that again and say that's not quite what the GOC said. They did say that some private work is permissible, but you need to be looking at national guidance as well. And I think it's quite a difficult argument to make, to say if the government and the NHS are saying that routine work, and not routine GOS, but routine examinations of lots of things, isn't a good idea at the moment on public health grounds, that private contact lens checks is okay. So I would go a bit further to say it's probably not okay anyway, but also it's just not really necessary. We still have the GOC's loosening of their regulations at the moment to say that you can supply people contact lenses, and I think that's probably appropriate to say if somebody's not having problems, you've assessed them on the phone, their lenses are comfortable, their eyes are comfortable, they're seeing okay, to just give them those contact lenses after the remote consultation and see them in a few more months' time when things will be a bit more normal and the risk to the patient is a bit less, because we're still in the phase, as I said before, of preventing patients going somewhere unnecessarily, and that to me doesn't seem something that's worth getting them into the practice for.
Great, thank you.
Great, Mike was nodding away there, so I see you agree, Mike, which is always good. Last one, Kevin, before you get a wee break. Are we allowed to use NCT now that the college have approved its use?
Yes. Short answer to that, they've got some new evidence on that and then done some more assessments and decided that it's not an aerosol generating procedure, so it's not risky. So you're within 2 meters of a patient. Even if you've got quite a big machine, you're going to be quite close. So you've got to have PPE on, but it's appropriate to use NCT. And that's why you'll have seen there was a new declaration out from the government, because the college published their thing basically at the same time as the government sent out their declaration, which now doesn't have NCT as a thing you're not allowed to do when you return it to the health board. If you've returned it with the old one, don't worry about it. You're allowed to do it. Just don't worry about the form.
Brilliant, thanks.
We'll take a breather now, Kevin. So this next one is for the whole panel. Can we refuse to see someone who refuses to wear a mask?
Can I answer this one though? And then I'll have a break.
Go on then.
Yes, is the answer to that. You can practically refuse to see any patient you want to, as long as you're not, you know, making policies that are racist or sexist or something like that. But reasonable things in your practice, like I have a policy here that says you must use hand sanitizer when you come in the door, or if you want to make the policy that you must wear a mask when you're in this practice, that's an entirely reasonable decision to make. And if a patient doesn't want to wear the mask, you're perfectly entitled to say, I'm sorry then, you can't come in here unless you want to wear a mask.
Great, thank you.
Great, next question. This one's for you, Julie. Okay. Is it reasonable to bring in post-cataract patients who had surgery just before lockdown? And I suppose elective surgery started a few weeks ago, so we're going to be getting some more for the post-cap refractions.
Yes, I think it is reasonable, and it would kind of fall under what would constitute essential care. But I would be mindful about these patients that they also might be at high risk or potentially shielding. So I think it is important to ensure that they've been kind of triaged in advance remotely and spoken with an optician before proceeding with an appointment. Be my thoughts.
Great, thanks.
So the next question is for you, Brenda. We're getting a lot of calls from patients complaining of headaches due to presumed refractive changes. Is this permitted under essential?
It's kind of a grey area. Essential care is interpreted as appointments for patients that would be an emergency, but the practitioner can judge if the patient is not examined. This could be detrimental to the patient's well-being or sight. In practice, what I would do a telephone triage, and I would ask the optometrist who would exercise their own professional judgment and decide if that would be beneficial for that patient or not to have the examination. Until further notice, the following supplementary eye examinations can be taken, and it's a 2.8 for an unscheduled appointment without dilation, and that code's to be used for the supplementary eye examination for a patient who presents with symptoms, unscheduled visit, and within the normal interval.
So really it's a case by case situation, then you just need to take each case.
Definitely.
Thank you.
Thank you.
Next one's for Julie and Kevin, another mask question. Due to an underlying health condition, I find it difficult to wear a mask for long periods of time. What do you advise?
I'm just waiting for Kevin to jump in like, masks!
Yes. The rules say the required PPE is a mask. And that's the end of it, essentially. But if you've got something that makes that difficult, you want to do as much as you can to try and mitigate that. So maybe you can do the telephone consultations. Maybe you can work from home if you've got other people in the practice who can do the other work, that sort of thing. But the main thing is, if you're seeing patients, you need to wear a mask. Now, the guidance has always said a mask is reasonable to wear for sessional use. So that means you put it on in the morning and you wear it maybe till lunchtime, and you wear a separate one in the afternoon. Once you've touched it, you throw it away. Maybe in this case, you might want to just wear it for a little while, an hour or two, and then take it off, have a breather, that sort of thing. And so you can make some modifications around that. The local GPs I've spoken to have said it's quite difficult to use 2 masks a day. They reckon it's more like 4 or 5 by the time you occasionally have to have a drink or go and use the facilities, different things that you're going to have to take it off for. So it's not unreasonable to wear it for a little while, take it off. But if you're seeing patients, you need to wear a mask.
Yeah, I would agree with that. I think as well, if there's anything kind of underlying kind of health conditions and you're not able to wear a mask, or then I think it would be a case of speaking to GP to see if there's anything that you can do with that as well. And don't forget, some people, if you are unable to test, if you're shielding, you know, you can contact your health board as well. So that would be something that you could also do if you're not able.
Great, thank you. Next question's for you, Julie. Can hospitals that use community optometry be encouraged to write to the referring practices of all patients they operated on or seen, say, February and early March?
Yes, I mean that would make sense. I suppose these patients would qualify as essential care, so it's certainly something that we could feed back to secondary care. Yeah, that would be good.
Great, thank you.
Thank you. Good question.
So the next question is for you again, Julie. NHS hospitals are seeking to get us to do more of the routine stuff for them. How onerous is this going to be, and can we refuse or ask for it to be delayed? So basically, if secondary care are asking us to do
more. I mean, this kind of development obviously would, I think Mike had kind of touched on it earlier as well, but it would require kind of new clinical guidelines and arrangements in place, and obviously the appropriate funding to manage these cases, as it would be out with kind of normal GOS. So yeah, I don't know if anyone else has got anything to add on that.
Kevin?
Muted. You're muted, Kevin.
Sorry, I got your message at the same time. I didn't hear what you said though, because I'm trying to read what you said at the same time. Was that cataract, post-cataract assessments?
Just for if secondary care are referring, for example, if they were to discharge glaucoma patients to us, can we refuse or can we ask for them to delay that?
Yeah, I think it's certainly a discussion to have. If it's a problem, if we've not got the capacity for it, it's certainly something we need to talk about, probably at OS and certainly in your local board as well, to say this is not something that works. You certainly need to discuss the funding of it if they're wanting to discharge patients that are going to be onerous and don't just need a regular checkup, but are something that's a bit more complicated. But yeah, it's certainly a discussion we should be having and not just taking these patients. We definitely want to help out because hospitals are going to be finding the next little while difficult, but that can't be at the expense of everything else that we have to do.
Yeah, I think there's a number of points here to be considered, because there is a new clinical governance structure that needs to be embraced by both sides. We need to get good communication links going, and we need to find a way of resourcing it adequately so that because this is us moving further and further away from normal commercial activity. If practice are going to remain viable and be able to take this on board, then the funding needs to be realistic. And I'm sure Mike understands that fully. I see you're smiling, Mike. Thank you.
I'm nodding.
So the next question is another Scottish Government question. Mike could maybe chip in here, but it's to Kevin. Would the Scottish Government consider the possibility of splitting the health check from the refraction? So a bit of blue sky thinking here.
Yeah, I mean, I suppose that is a question for Mike more than me, but I also don't think it's probably in Mike's gift, because it's not Scottish legislation that defines that. It's the Opticians Act that defines that, which, as I've mentioned a couple of times already, and it probably is a question I'm getting. I'm sorry if I'm using terms that are mixing up. I think I said a regular test and that sort of thing. You're not allowed to claim a primary examination at this point, but as we've talked about already, it doesn't matter anyway, because everything you claim doesn't matter. You're getting your emergency funding. What I wasn't meaning by that was claiming primary exams. I mean, if somebody comes in with an issue that seems to be refractive in origin, you do what we would, call under the regulations a sight test or an eye test. You do a refraction, you look at the outside of the eyes, the inside of the eyes, and any other normal test you do for these people, like IOPs if they're over 40, that sort of thing. But at the moment, it's not possible. It's against the Opticians Act to do a refraction only and not anything else. And even Mike, if you wanted to, couldn't allow that to happen without change to that.
Yeah, I mean, I don't really have anything further to add to Kevin. And amending that piece of legislation is primary legislation, which requires something to be done at Westminster. So it wouldn't, it would take a long time to do as well. So yeah.
And the AOP's view, we toy around with this, and we have for years now, is it's probably a can of worms we don't want to open, because it doesn't actually restrict us from doing very much. We can still do all the other stuff we want to do about Sharecare glaucoma and treating community eye disease and all these things, but it also protects us quite significantly from other people nicking that part of our work, which is quite important to our livelihoods. So if you can only do, a quick refraction and sell some specs, that gets rid of quite a lot of what's quite important to our businesses.
Great, thank you. So the next question is for Julie. For practices that are not reopening in phase 2, if their patients phone us, who should we direct them to?
I think if a patient phones you, then I feel that you should do what you can to look after them to the best of your ability, just as you would in normal circumstances. Any practice, obviously, that remains closed or inactive should really be signposting patients to another local practice. Want to save patients having to travel unnecessarily to different areas, and they could communicate through voicemail, website, window signage, emails to patients, anything like that. But no, I think we should be doing our best to look after them if they've come to us.
Absolutely, we have a duty of care, really, don't we, to make sure these people are dealt with. Yeah, good.
Another one for you, Kevin, and it's been partially answered. If a practice reopens on the 29th but is unable to provide the full testing hours, which it previously did, do they still receive GOS support?
Yes. There's not, as Mike said right at the beginning, we're not like a pharmacy. The pharmacists have quite a strict contract that says you have to have a pharmacist on the premises a certain number of hours. We don't have an agreement like that. We just have an agreement to provide GOS. And there's no expectation that you're sitting behind your waiting reception desk 9 till 5 all next week waiting for half the number of patients who used to contact you. So it's absolutely reasonable to provide a part-time service and every second day service, that sort of thing. It's certainly useful to be contactable. And if you've got a phone, that means you can be diverted. So the day you're not there, you can speak to patients, as Julie said, and either go and see them if it sounds important, or book them in the next day, or direct them to the eye hospital if it sounds a particularly serious thing. But you absolutely don't have to be there full-time hours. You just have to be able to provide those face-to-face appointments when required, and then you get the support for that practice. And as we talked about earlier, the reverse of what we talked about is if you've got 2 practices and you're covering between the 2, as long as you're available to see patients in either of those practices, you get the emergency funding for both of them. But if you decided you were just going to keep everything in one and not see any patients in the other one, you would only get funding for the one of them. So open both, but it's a financial decision for you to make.
Yeah, that makes sense.
Thanks, Kevin. So the last question that we have for the pre-submitted questions is, what will happen if a whole practice has to self-isolate due to a COVID outbreak? Will they still receive the average GOS? And that's for you, Julie.
Well, yeah, I think we've kind of touched on bits of this before, but it's kind of covered in the most recent PCA. If you can provide details to your local health board, they will make the decision. I think NHS boards are obviously expected to consider all aspects as to why you're not opening, and if sort of circumstances come up like that, then as long as you're communicating with them, I think that illness potentially would be favourably considered.
I would absolutely agree with that. I would just add that I remember to avoid that as much as possible. It's the same as the trace and protect. keep 2 meters away from all your staff. If you'd never go within 2 meters of somebody, even if they develop symptoms, you wouldn't have to self-isolate. So if your whole practice has to self-isolate, you've done something wrong. You've had a group hug or something that you shouldn't have done. So if you stay away from each other and keep your PPE on, you'll not have to do this. But absolutely, that's a perfectly valid reason. If a practice came to me and said that we've had a horrible accident, this has happened, we'd be saying, that's fine, you know, put guidance in place to direct your patients to somewhere else, but you don't have to be open. You can't be open in that scenario, that'd be worse.
Yeah, I'd agree. I think health boards would look very favourably on illness as a reason for not being able to raise the shutters and function. And we had an example in North Lanarkshire, a practice, a dental practice actually early on in the COVID crisis, which closed down completely because 2 members of staff became infected, and obviously the rest of them were having to go and self-isolate for 14 days and the practice closed. That has happened already.
Yeah. Now we're going to go over to the questions that have been submitted live tonight. So we have them, Emma sent them over to us. So Ali, do you want to start us off with the live questions?
Absolutely, and just before we start that, if anyone's got any questions, just post them in the feed, don't be frightened. I know you're all having discussions in the Facebook feed, so if you want to ask a question directly, there's no silly questions on here. So the first question is, will there be any secure platform offered to local health boards for remote video consultations?
Yes. Anybody can have an NHS Near Me account, or what they call it, I've got it on my phone right here.
Attend Anywhere?
There's a link I've
given. Anywhere or Near Me.
Anywhere, yeah.
And you can sign up for your own, they attend anywhere, that's the word I was looking for. So you get your own waiting room. So you put your practice details in, it really has to be the owner of the practice, but then you can invite the other clinicians in your practice to sign in the same account, and you log in, give the patient the link, so you can put that link on your website somewhere, maybe not right on the front page, but somewhere they could find it. Patient clicks on it, they come into your waiting area. It's brilliant. It's a really good service. It's secure. It's NHS approved. It works really well. So we can certainly send that link out so people can sign up for their own account.
Yeah, it's very good. Grampian have been using it as well with their EETCs, and I know a lot of the optometrists there have been raving about it. It's been really good. They've just been able to be on the phone to a patient and then ping them the link, and they've been able to just meet them on a video call, and they've said they've managed all ages. It's, you know, and you don't have to be good at computers to follow the link. So yeah, it's been brilliant.
Yeah, I think in the early stages it was set up as a communication tool, case sharing tool with secondary care, and it's morphed from that, and I see great advantages about case sharing across primary care between pharmacy and GPs. And obviously the next stage in that, as Kevin described, would be perhaps remote video conferencing with your patients. And a lot of people are doing that with WhatsApp and other things just now anyway, but this is just an NHS regulated method for carrying out these assessments. I think it's certainly the future.
Do you think it may become used to communicate with secondary care, between optometry and secondary care?
That's what it originally set up for that. We're doing a pilot in Lanarkshire just now with 12 practices, and just to try and iron out all the glitches, and then all practices will be invited to participate. But I think the big advantage long term, bear in mind, only about 4% of what we do gets referred to secondary care. There's an awful lot of activity happens internally, and we could perhaps make better use of OCTs and other pieces of specialist equipment and the IP resource within communities to try and make things better for patients and retain even further more patients in the community and deal with them more effectively. I see loads of advantages with it, yeah.
We've been using it in Ayrshire and Arran, and the part that I like is it's obviously NHS branded. It looks very good for the patients, and it certainly looks as if they're in an NHS examination. So yeah, really proud of it. So thank you for that.
So the next question that we've received is an AOP related question. So it says, where do we obtain the AOP certificate after doing the hygiene webinar?
So you have to pass the CET. I got 100%, I was pleased to say the other night. And then after that, you can log in and get the certificates. I think I'd have to double check where you do it, but if you log into your, I think it's called My AOP on the website, and you can look at the CET you have done, you can download a certificate for that there. It sometimes takes a few days with these online ones by the time I've uploaded all the points and that sort of thing, but you'll be able to download it from there.
Yeah, I've certainly done it on there and it worked fine. good for showing the patients as well. So next question is, Kevin, sorry, you're been asked to clarify something. Could Kevin clarify tests required if coming in due to broken, lost glasses and lash refraction more than 2 years ago? It's confusing what's required and what's the same.
So that's back to what we said at the beginning, what I said at the beginning, so sorry if I wasn't clear. You don't have to examine that patient. You could just make them new glasses from a prescription. You're a professional, you're allowed to make that decision. Is that the right thing to do? And maybe for a particularly vulnerable patient, a patient in a care home, I would be saying, you know what, make them a pair of glasses to the same prescription if they feel they can see okay. But if you feel it's appropriate to examine them, and especially if they feel their vision's changed, or it's been 10 years since they had a test, it would be reasonable to examine them and do all the tests we would normally have done in the old days. So refraction, obviously, check the outside of the eyes, check the inside of the eyes, measure their IOP, and then anything else you think is necessary after that. So a basic normal sight test or normal eye test, sorry, I'm using the English terminology here, I mean, AOP day today, probably the sort of thing you would do under a 2.8. You know, if somebody came in and under a 2.8, you do a basic test, including those procedures. And I saw somebody had asked, is it okay to do just a retinal photograph instead of a proper internal examination? And I would say no. Again, a couple of months ago, that was reasonable when we were in that really strict period. But now we're saying, with your PPE on, have a look at the back of their eyes with a Volk lens in your slit lamp.
Yeah, I think we should maybe direct people to the sight testing regulations from 1989, which specifies this very, very clearly, that if you're doing a sight test, it's not just a refraction, there's an internal and external examination of the eye and any other appropriate test deemed necessary. So again, it comes down to that issue about clinical judgment. So I would direct people to the GOC website and look at the specific regulations to keep themselves in the straight and narrow.
Great, thank you very much, guys.
Because I think a lot of people don't always do an eye exam, a full health check when they're doing a retest as well. So it's good to confirm that the Opticians Act 1989, you must do the eye health check also. Good. So the next question is, can we do refraction if visual problem in phase 2? Do we claim a primary?
No. You can only claim supplementaries. The last PCA listed the supplementaries you can claim, and it makes a lot of sense. It's only the ones you could do if a patient presented to you with a problem, or if you recalled them to investigate something like a 2.3 for a suspect glaucoma. You can't do the ones that follow on primary, like a 2.4 dilation after a primary, and you also can't claim a primary. But again, it's a bit of a moot point because you're not getting paid for the claims you submit. We're just being asked to do that. You're getting paid your emergency funding anyway, so it makes no difference. So do the test you have to do to investigate the patient, remembering the law as we've discussed a couple of times, and then claim the appropriate supplementary code for what you've done.
I think you should be borne in mind, but you're not getting asked to make the claim to be paid. You're making the claim so that the government is in a position to assess the data collection, or to make to look at the data as it comes through and analyse it for going forward. So that's the main reason we're asking you to do it. You can ask to do the extra work, but hopefully everybody will sign up to it, and we'll get the data that we need at the end of it all.
I think that's a good point. Mike was nodding away. Data collection is vital for us at Optometry Scotland and the government to move forward out of this crisis. Next question was, can I just make sure everyone is aware that post-cataract reviews are essential? Surgery will resume on 29th June 2020. I assume that's from someone in the profession that said that. I think we've covered that, haven't we? Essential cataract post-cat checks. And I think we're all in agreement there.
Yeah, I think we've agreed that that would be essential, Eyecare. Yeah.
Great, great. I'll just ask the next one if that's okay, Emma.
Go ahead.
Kevin, you've spoken about normal tests a few times. Can you clarify no primaries? Yep, we've clarified that. I think in that point, I think there'll be obviously a lot of optoms out there that have been in furlough. And for coming back, they should definitely be looking at the PCAs that are available on Optometry Scotland's website, and also possibly local health board stuff that's maybe been coming into practice emails rather than personal emails.
Great, thanks, Ali. So the next question is there any advice for asthmatic practitioners in the use of a mask?
I don't know of anything specific, other than maybe trying to use the mask intermittently and being careful about what you're doing. It's the one that you understand that the asthmatic people are part of the risk group, and they're probably more at risk of COVID than the next guy or the next girl. So they need to be careful what they do. Everybody, there's underlying health problems, and I think all of us have asked questions of our staff when we're undertaking a health and safety risk assessment recently. If they've got any underlying problems, then you've got to try and manage that as best you can. And it may be that individual in a big practice could do all the tele-triaging and the others could do the face-to-face. It is a difficult one and need to be looked at on a day-to-day, case-by-case basis.
Yeah, I'd agree with that. There isn't anything I know of particularly. I think it would certainly be worth talking to your GP, partly because they'll know a lot about asthma, and partly because doctors are much more familiar with wearing a mask than we are, so they maybe got good practical experience or tips there as well.
I think as well, if you're asthmatic, it's just important to keep monitoring it. If you've got a kind of peak flow, you can monitor it yourself. Just make sure that everything is working as best it can, really, as well. If you're going to then be wearing a mask, that'll be an added thing. So if you can monitor it yourself as well, I think that would be
great. Thanks, guys.
The next question has already been answered, but I'll just make sure. Does retinal photography constitute internal eye examination, or does it need to be VOC/direct?
I would agree with, I don't know who said it earlier, I think it was probably Kevin or Julie, but I think that we need to carry out the examination as per the regulations, and that is carrying out for the purpose of detecting signs of injury, disease in the eye, an examination of the external surface, and an intraocular examination. And I don't know whether a photograph could be called an intraocular examination. So I would suggest that you need to get your Vogue lens out. And during this COVID period, obviously, we're trying to discourage folk from using direct ophthalmoscopy to try and keep some semblance of distance from the patient. So a Vogue lens would be the method of examining the internal eye just now.
Yeah, I would agree with that. I think I would go slightly further in that, partly because the Scottish GOS says you should use a Vogue lens and a slit lamp biomicroscope, and partly because of, as Frank said, the COVID thing. You don't want to be anywhere near somebody with a direct ophthalmoscope. I would say do not use the direct ophthalmoscope. Use a bio headset if you have to, if they can't reach your slit lamp. But yeah, not a photograph.
Use a direct ophthalmoscope for pupils. I think that's about all I use it for these days.
So the next question we have is, what changes are being discussed or proposed for changes to essential care in phase 3?
Not much so far. There's been some background discussions about whether we would be in a position to look at a structured method of monitoring or managing or co-managing shared care, delegated care patients from secondary care. Mike and colleagues are looking into that just now and trying to consider funding arrangements, etc., to make that happen. Certainly, from my knowledge in the health boards that I work in, that we haven't had any significant discussions about the clinical governance around that and how these patients would be identified and how they would be discharged into the community. So right now, I don't see any significant changes for phase 3 other than what we're doing just now. Then maybe a little bit, maybe loosen the reins a little bit to do a little bit more activity closer to routine care. But I don't think routine care will be allowable until we get to phase 4, which might be a couple of months ahead at least. And that would be when there's almost serious suppression of the virus, and so that we know that the public are at minimal risk.
Thank you, Frank.
Great, thanks. Next question, again, we've kind of partially answered this, but it's very specific. If someone with a 4-year-old prescription has lost their glasses, is carrying out a refraction deemed essential eye care, or are we expected to use the prescription from 4 years ago? So again, I think Kevin was saying it depends on that person.
Yeah, it could be an essential. I think that would be a reasonable one to do, but you could also decide it was reasonable not to do it and just use the old prescription, as I say, particularly if the patient's particularly vulnerable. So it's really a case-by-case thing, thinking about how long it's been, any health conditions the patient has, and all sorts of other factors at the same time. So absolutely up to your professional judgment to decide if you should see that patient or just make them new glasses.
Absolutely. I agree completely.
Yeah, I think it's hard, obviously, using a professional judgment. We're used to such strict guidance. I think everyone's just kind of struggling where to put that. But you're saying basically if you put that in your notes, you'll be absolutely happy either way.
Yeah.
Great, thank you.
The next one is just more of a sort of general statement. This is a time to review GOS codes to introduce more flexibility to support community optometry, providing acute eye care and working in tandem with hospital eye service.
Yeah, I think we've covered all the basics around that, and obviously this would, if we're going to look at delegated share care activity, it probably won't be part of GOS per se. It would be an enhanced service, and there would be a different structure to that, and probably a different funding stream to make sure that it can work and work effectively for optometrists, so it's viable for optometrists to engage in the activity, but also that it works effectively for hospitals. So it's a bit of a new ball game, and it'd be quite broad ranging. It could look at vitreoretinal disease, glaucoma, maculopathies. There's a whole range of activity where we could probably provide a good bit of support for secondary care going forward. Yeah.
Great, thank you.
Great. Next question. Can furloughed optoms from one optician help out with another optician who need the support temporarily in these times?
Yes, would be the answer. So they can volunteer or work elsewhere while they're furloughed. If there are days that they're not supposed to be working with their employer, and their employer would have to agree to that as well. The employer can't benefit from it. So the optician working for the other company would have to be employed temporarily by them, or as a locum optometrist. You know, it couldn't be that one optician or one practice pays another company for their optician because that optician's on furlough. But yes, they can volunteer or work elsewhere during that time.
Just throwing a wee spanner in the works here. What happens if the original employer is paying the full 100% of that optician's wages?
That's the employer's option, but it doesn't stop them as long as they are able to work if their employer required them to. But no, it doesn't affect it. In Grampian, actually, we had a lot of optometrists working effectively for Grampian during the lockdown. So they were working in the EETCs, and they were potentially getting paid whatever their whatever was in place with their current employer. But the Grampian were also kind of effectively employing them working.
That's great. Thanks for that answer.
Thanks, Julie. So the next question is, what is the best solution to use to sanitize equipment?
The stuff that's in the bottle. Just scoosh it, or the wipes. I guess there's loads of products out there, isn't there? And most of them are bactericidal and virucidal, and just need to check the contents, whether it's alcohol wipes or benzalkonium chloride or whatever products there. Read the label and be sure that you're being safe.
Yeah, I'd agree with that. And you've got to be a wee bit careful sometimes with certain things. Alcohol wipes are really good for little delicate instruments, not as good for other things, and vice versa. And if I could flag the AOP video, you can watch that. You don't have to be a member. We've made it available to everybody. You don't get the certificate if you're not a member, but you can watch it. There's good guidance in there. Things like the Clinell wipes, maybe some of you are familiar with, are good for wiping big surfaces and that sort of thing, but there's lots out there.
Great, thanks guys. So the next question, I think a lot of us were under the impression that we should be doing only the necessary tests within restricted time in the test room. However, it sounds like the advice tonight is that we should be effectively doing a primary examination, refraction, and fundus exam for every patient.
No,
definitely. And Kevin's that wasn't the previous question was around when you're carrying out a refraction and sight test, and then you encroach onto the sight test 1989 regulations. So that's a different kettle of fish. If someone's got a red eye, there's a supplementary examination, and we can carry out a supplementary examination. The difficulty comes when you start to consider carrying out a refraction. Then you've got other legal obligations associated with that. And that's the difference between carrying out a range of minor external eye assessments, carrying out a vitreoretinal examination, or whatever. But the difference kicks in as far as the legislation is concerned when you carry out a refraction.
Great, thank you.
Next question is, if you are a locum, do you need to register for Near Me or Attend Anywhere with every practice, or will one code work for every practice?
No, I think you would want to have one for the practice. It's held, the waiting room is assigned to the particular practice, so you would want to have access to that practice's waiting room. When you're working for that business, you get patients for that practice. So you want one. You can't have an individual one that you just use as your personal one. It is assigned to the, as far as I know, it's assigned to the practice. But that practice owner, if you were working for me, I have permission to add other people to it. So I would just add you in as the person working for me at the moment, and then you can use it with your device.
Yeah, Kevin, I think you get one for you personally, and we've got 4 practices, so I can add my Optoms to every practice. So I think you do get one personally, one code, one password, for example.
Yeah, so that's your personal login to the system, but you then need to be allowed to access that business's waiting area.
The administrator needs to add you.
Exactly, yeah.
If you're a locum, get added in advance before you turn up. Okay, thank you. Bear with me. I'm just next question. Do we have to do fields on over 60s first time visit?
No, not for quite a long time now, isn't it? Well, partly, I mean, we're not doing primaries at the moment anyway. Even if we were, that's not in the current regulations. That changed years ago. I can't remember when now, but it was quite a long time ago.
Yeah, we changed that in the regulations about 18 months ago. Well, nearly 2 years ago now.
A long time ago. 1,000 years ago before COVID, yeah.
Who can remember pre-COVID?
But that's back to what we were saying earlier, that you just need to do the test you think you should do, other than, as we keep saying, when you do a refraction, you have to comply with the law. Other than that, you just do what is necessary to investigate that patient's problem. So if it's a funny glaucoma thing, you're probably doing visual fields. If it's an anterior thing, you're looking at the outside of the eye. If it's a flashes and floaters, you're looking at the inside of the eye, and you just do what is necessary.
Great, thank you.
Thanks, Kevin. So the next question is there a maximum time for being in a test room?
No.
I think that the crucial thing here is to try and minimise contact time with patients as much as you possibly can. And a lot of that's down to some semblance of pre-assessment, maybe interviewing the patient on the telephone for history and symptoms prior to them arriving, or calling up their emergency care summary so you better understand their general health, so you're not going through all those questions, and then doing what you need to do in the consulting room and dealing with whatever issues the patient might have, and carrying out your treatment plan or whatever needs to happen. But there's no minimal time. The important thing here, as I mentioned earlier, is making sure the room has good, adequate ventilation, and that tends to mean that you could be there for quite a long period of time.
And you can also take steps within the room to distance yourself from the patient. You know, in the old days, my test chart is behind me, or my test chair is behind me, and I've got a computer right next to that where I sit and make my notes. I'm not going to be doing that anymore. I can't show you because I'm looking at it right now. I bought a new mini one that I can now sit on the other side of the room. So I'm not sitting within a metre of the patient. We can sit and have a chat with a 3 metre distance between us, which again is just helpful for not having that close contact with patients as much as possible.
The nuisance about using a visor in a consulting room is that you obviously can't use it with a slit lamp, but you should have a breath shield on your slit lamp, which would help. And maybe if you've got to do other up close and personal things with a patient, put the visor back on to get up there just to be that little bit safer. But you're right enough, you can question the patient from 1 metre to 2 metres, and if you've got your PP on, you should be fairly safe.
Great, thank you. Next question is, how will the Scottish Government know how many people we consult with over the phone or video as opposed to face with the codes?
They won't know the difference because you would claim that as a remote consultation, but that's just a claim. So maybe a 2.5, it was an eyelid thing, but they wouldn't be able to tell the difference from just looking at the statistics. I don't know if anybody's thought about how we could gather that sort of thing.
It's all
There's what behind Brenda, that's what I'm laughing at.
So the next question we have is, should we also submit GOS3 vouchers if we supply glasses, even though we cannot claim the fee?
Yeah, I think we want you to do that so that the health board wants you to do that so that the claims can be monitored and data can be collected effectively.
The only one you get paid extra for are the HEST forms. So if you get a HEST 3, you put that in and you'll get that on top of your emergency funding, or a HEST 4, but they're a rare thing.
Okay.
Procedure for GOS3s is the same. Complete everything and submit it.
Yeah.
Yeah.
Next question.
But it's good for data collection.
Great. The next question is, are under 16 reviews or 6-month VA refraction review essential?
Maybe. I think I might be, if we're starting to look at those next week, I've not got any staff at the moment, so I've not done it yet, but we'd have a look down the reminders, and I'd probably want to pull those records and say, what was I looking at? If it's a funny amblyopia one and the kid's getting, 6 or 7, I might say yes. But if it's just somebody who's a bit short-sighted, maybe we'll phone them up and say, do you think you're still seeing okay? We can probably wait a little bit longer. So I think that's a case-by-case one for those ones. So could be.
Okay. Stick it in the notes and make that professional decision.
Yeah, absolutely. Yeah.
Okay, so the next question we have is, how long does pre-made up sodium hypochlorite last?
You got 100% in the video, Kevin.
Kevin, you've got this.
That question. My colleague will be able to answer that. Maybe watch the video, it'll tell you. I don't know the answer.
I'm pretty sure it was 24 hours when I watched or seen the table, but I might be wrong.
That rings a bell from something I've seen. It was about cleaning frames. Yes, I think that's right. It said you should make up a fresh batch every day to use because it loses its effectiveness. But I can't guarantee that's the answer.
Thanks, guys. That was a tricky one.
Sure was.
Next question. Can patients looking for new frames come in to browse?
This is a difficult one. We've had a long discussion about this because we're looking to try and everybody's looking to introduce the door access control, whether they lock the door or whatever else, or they're getting folk knocking the door to come in. And I don't think it fits easily with folk walking in and having a browse around. In my practices, we try to separate into zones so that the person stays in the one zone, and if they want to look at product from a different product, we bring the product to them. It's a tricky one. It really is a tricky one because people moving around and they might get, and you can see it in supermarkets now, they lose all sense of safe distancing. And the same thing would probably happen if you had a load of people browsing around your practice. So the safe distancing thing is the issue here. If you've got a massive area and you can keep folk apart, then it's probably okay. But other than that, it would need to be given some careful consideration.
Yeah. I think what I would do, because I work in a small practice, I would actually sit them at a dispensing area so that they're not going about the practice and you've got more control over what they're touching and managing to clean the surfaces that they're touching and in contact with. And I would make sure I brought the frames to them so that you knew which frames were touched, that you could sanitise them properly.
So I think what we're saying is there's no rule against it because you could be a normal shop, your next door could be selling dresses, for example, but take relevant steps, have appointments, for example. You should know who's coming in, doing the screening, and questions the same to protect your staff, etc. And that's reasonable. Great, thanks, folks.
So the next question we have is, how do we access patients' emergency care summary?
A lot of health boards have given you access to that. If they've not done it yet, they're working through the process. We started with IPs, some areas started with the EETC people, and it's rolling out over the next little while. So you'll be given a password. It's basically just the same as Sky Gateway. You log into that using either your token or your new CAT20 if you've had that installed, which I'm pleased to say is nice. You don't have to do anything now. I just press a button and it comes up. I don't have to find my token and things. And then you log into the ECS with your password in the same way as you would with Sky Gateway, something like that. On that note, can I a quick plug? If you've not used your Sky Gateway in 3 months, you might want to start thinking about how am I going to get the password reset, because I bet lots of people have forgotten them or they've expired. So you might want to do that before Monday, just in case you have to use it.
That's a good tip, Kevin. Thank you.
and all other passwords, by the way, once you get in front of that PC. Yep, you definitely need that. So next question is, are fans or air conditioning units allowed to be used whilst examining patients?
I think the air conditioning is frowned on a little bit because it's recirculating air, and I guess fans are doing much the same, but I don't know of any rules.
It certainly depends on your system for aircon, particularly if you've got a system that pulls air out to outside, that seems to be quite good. If you've got one that just circulates around the building, that's bad, but you really need to look at your specific device and see what it is. I think fans is a bad idea. That just feels like a bad idea, blowing breath particles around the room. But aircon, you need to look into your particular system.
Great, thank you.
And the last question we have so far is visual fields necessary for flashes and floaters patients?
And can I start, because this is a personal bugbear of mine? No, I almost want to say it's a complete waste of time. If you've got a detachment that you can detect in a visual field test, which only really assesses kind of the middle bit, you've got one you should have seen with an undilated pupil. It's not the test you need to be doing to rule out a retinal detachment. It's of no value. The test you need to do if somebody has flashes and floaters are dilate their pupils and look with a binocular method into the periphery, have a good look around, make good notes of that, check for tobacco dust, and that's it. Visual fields is practically a waste of time, and it's certainly not something to do instead of dilation. You do the dilation every single time. You might want to think about visual fields in normal times, just to give you something to do while they're dilating, but it's not a necessary test at all.
Yeah, I think I would make a wee plug for the CCI flashes and floaters pathway that I was involved in developing about 10 or 15 years ago, and it's idiot proof. It's an idiot's guide to detecting retinal detachment. And I don't think that we've mentioned visual fields once in it.
Great, thanks very much. Before we go to Emma for the kind of closing thanks, Dave, do you just want to bring yourself off mute if you want to speak to everyone?
Yeah, listen, I'd like to thank, we've had nearly 600 people, over 600 people at one point joining us this evening, so I want to thank you very, very much for joining us. I just want to take this opportunity to thank all of the OS executive who's really sat behind the scenes in arranging this whole event, and all of the weeks and months of work that's gone into trying to prepare for tonight and beyond. So very, very huge thanks to the OS executive for working so hard. Big thanks to our panel and our presenters tonight. And very much to Mike as well for giving up his time this evening. It's not often that you'll get people from any government willing to put themselves in front of a panel, never mind in front of 600 colleagues. So thanks very much to Mike. Great job, folks. I hope everyone's delighted as I am with this evening. I think it's gone really, really well. We've had some great feedback, certainly being fed back to us right now. I think what's important as well, we received some questions prior to tonight and during tonight. I think it's really important these questions keep flowing in. Everyone's really sensitive to a lot of the feedback we get, so keep it coming. It's very, very important. Please keep that coming in. And again, depending on how you felt this evening's gone, I think we'd be more than happy to hold more of these as and when it's relevant. So thanks a lot. Over to you, Emma.
Just again to thank everyone for joining tonight's webinar, and to those who submitted the questions. I hope everyone found it useful. If your question hasn't been answered tonight, then feel free to contact the Optometry Scotland office. You can do that by phone or email, and you can find the details on the Optometry Scotland website, which is optometryscotland.org.uk. A big thanks to tonight's panel. I'm sure you'll all agree a vast amount of work has been done by Optometry Scotland with regards to negotiating favourable terms for the sector. OS are committed to continue the relationship they have with the Scottish Government, and we will continue to update the members with any progress along the way. So a big thanks to all our members. With your support, we have achieved so much, and with increased support, we can strive to achieve so much more. So if you would like to become a member of Optometry Scotland, you can find the details, or you can join on the Optometry Scotland website. And that brings us to the end of tonight's webinar at 19:30. So that was good timing. So thanks again, and have a good night, everyone.